We begin with when the window closes, surgical pearls to maximize your outcome in an intraoperative meiosis. The most challenging case for us is when we've prepared very well, we've gone into the OR, and the pupil is all right to begin with, and suddenly, or it wasn't that well widely dilated, and suddenly we see that the pupil has come down. So now starts all the complications that can happen. The intraoperative challenges of small pupil are really a lot because number one thing is that limits your visualization, and once that happens, there's a series of problems that can happen. Number one, your capsular rhexis may not be an adequate size. Once that happens, your nucleotomy will be compromised because you will not know how long a groove you have to make and how are you going to split this nucleus. There could be an incomplete cleanup. The pupil may come down even further, and there may be an incomplete cortical cleanup, or there may be a fragment of the nucleus that has been left behind, which causes inflammation. And in case you're doing, these higher-end IOLs, where you've promised a toric IOL placement, where exactly are you going to place it, and how are you going to check whether the IOL has been placed well or not? Because these are going to be the problems which you're going to face. So the first thing that we have to do when we have this is try your luck. We have the epitrate in your OT that should be ready, and if you're lucky and you've put in the epitrate, this pupil may enlarge to a considerably larger part, and usually these intraoperative meiosis usually happens after IA. That's because you're trying to clean up the cortex behind the iris, and the pupil comes down with the fluid wave coming in. These are the cases where we've tried to do our rhexis, a small rhexis. This was a case which had a glaucoma earlier. You can see that it has a YAG PI also, shallow AC, and pupil is not dilating. So you do a rhexis which is a smaller, but it has to go beyond the pupillary margin, because once you do that, you will realize that it is easier to hydrodissect also, and also the important pearl while doing nucleotomy is stay safe. These lenses sometimes are very sticky, they do not crack, but you need to just keep on teasing them and bringing them in the center. And cortical cleanup also, if you're doing a very successful circumferential systematic cleanup, it becomes easier. This is another case where the pupil is stuck and there is a posterior synechia. So with a Lester's hook, after putting in a good OVD, you should not compromise on an OVD in these cases. You just need to open up this pupil. This is a case where a toric IOL was required. And as I said, it's very important in a toric IOL that we need to check the axis. So once preoperatively you mark the axis, you need to again stay at the center, get the rhexis done beyond the pupillary margin. So important part here is to hold the rhexis at the margin at the end with which you have left as a flap. Hold, and you pull it out. Here again, we are doing a very gentle hydrodissection. It's a sticky kind of a nuclear material. So a very gentle putting of the fluid and nudging of the nucleus is done. So that once you see, and it's very empirical in these cases that we need to see that the nucleus is mobile. Take a minute or two to do this maneuver, because here this is your end result. If your lens has moved and it is rotating easily, then things get easier. Since this was a case of toric IOLs, we are putting in these hooks. Now, whenever you're putting the hooks, the important trick here is that you need to make these paracentesis for here, as I'm doing it here. These have to be made very peripherally. Don't go too anterior, because if you do that, you'll cause tenting of the iris. And if you want to prevent, because most people say that, post-operatively you've had after the surgery, the pupil has not come back to its normal size. So very important part is that you need to know when to stretch it and when to release it. So at different parts of your duration of your procedure, you must release the iris hooks also. Don't just let them be where they are. because you can release it, like I released it now. But because I don't want any of my incarceration of the iris tissue into the injector while I'm putting in the lens. And so, and at this moment, it's quite a reasonable size dilatation of the pupil. The lens has been put inside the eye. We can see it well, and it is dialed in at the right place, right axis. Now here again, to prevent capsular phimosis, because this is a case of a toric lens, we don't want that there would be any capsular phimosis. So I do an extension of the rhexis. And taking out of the iris hooks is also very important. Always make the hook parallel to the iris. And once you've done that, and the visco has to be adequate, and then you slowly take it out. Because if you tilt it, you're going to have a DME, descemet membrane detachment there. So you don't want to do that. So this is the other few tricks during this. Now there are a lot of complications that are related to the small pupil. There could be iris damage, because especially in cases of pseudo-exfoliation or cases where there's a floppy iris, ephes. So the iris, there's a lot of bellowing of the iris, and it gets caught in the phaco probe, or there is a prolapse through your side ports. So there is chaffing of the iris tissue. There could be just transillumination defects, which the patient complains later on of glaze and halos. So all these have to be, you have to be very, very careful and cautious. Never overfill your chambers in cases of ephes. They should be always adequate viscoelastic. And IOL placement issues also could be there. One of the haptics could not have been put inside the bag because the pupil was small and you were not able to gauge where exactly you are supposed to leave your haptics. There could be retained lens fragments of the cortex. Now, retained lens fragments, one thing I would like to say is always hydrate the ports before leaving. And because sometimes it's just in the side port that it is one of the nucleus fragments is hiding, or in a small pupil it could be under the iris, which may later cause a CME or a glaucoma or any other problems also. And any case where you've done a lot of maneuvering with the iris, there are chances of CME. So if the patient is not having a good vision post-op, do an OCT to check and treat the patient accordingly. Thank you very much.
I think we have time for a few questions. Does anybody have a question? Okay, I have a question. When we talk about, say, premium IOLs, does the pupil size for you matter? And if you get a case of intraoperative miosis, how do you ensure that? Because for me, the biggest challenge in intraoperative miosis when I'm not using a device is if the bag, it's in the bag or it's not in the bag, if it's in the right alignment or not.
Yeah, so a word of caution here. In any time there is an intraoperative meiosis, if you haven't used the devices, then you must check that, sequentially, shift the iris, pull the iris, and just check your capsular margins. See that the lens is well within the bag. And if the IOL is mobile, it moves freely left and right, or whenever you want to rotate it, then mostly it is in the bag. So that's one of the signs in which you can test also. But you must take time to just ensure that the IOL is inside the bag by lifting the pupil and checking the margins of the capsule.
Thank you.
Yeah, thank you.
Any comment from the panel?
Very, very good videos.
Thank you.
Yeah, the Y hook is a fantastic tool to move the iris away, because most of the time the surgeon is working with Sinskey hook and retracting with that. But a Y hook is the least traumatic. It can hold the iris pupillary border nicely, and you can check all around whether the lens is in the bag. And I felt that it's a very, very useful tool.
Good tool. Yeah. Even when you're doing the IA, the irrigation probe, you can just sort of, that's only if it is not a case of ephes. If it is, then that is absolutely a no to do. You should not lift or go anywhere near the capsular margin. The fluid should not go under the iris.
Another thing is the relativity of what we call as a small pupil. What might be small to one surgeon might not be that small to another person. Depends upon the degree of expertise. Not only the expertise, also other confounding factors, like you said, floppy iris, very important. Sometimes you might be a little in the center, just a little away from the center, and a floppy iris can come.
Yeah.
So the decision regarding when to use the iris hooks is very critical. If you have a borderline pupil where you are not very confident about operating safely, it's perhaps better to use the hooks before you start off. It gives you a bigger rhexis and a lot of ease during the surgery. Like we saw one of those beautiful surgeries, you put the iris hooks later. But that depends on the surgeon's ease. But for beginners who are handling small pupils, I think an iris hook at the start, a pupil expander at the start of the surgery would be safer.
Also, what would be your choice of pupil expanding device in case of a shallow anterior chamber?
In shallow anterior chambers, I think hooks can work well, but only thing is that where you place your hook. So it should not be very anterior, it should be very posterior, it should be relatively on the periphery, so that it doesn't cause tenting of the already shallow anterior chamber. The rings can also be a good device to do. So between the two, you can see wherever you are more comfortable with, whatever works best in your hands, but you can use both, either of the two, I mean.
Thank you.
Thank you.
Next speaking, okay. Dr. Arun, you had a question? Okay. Please. You can use the mic, sir.
Yeah, the videos were very beautiful. You put the hook after you did the rhexis. Is there any trick where the rhexis does not get caught in the hook? Because I have burnt my fingers, the rhexis getting caught in the hook and then tearing off. And then
so in small pupil cases, and especially you have small pupils, I mean, there are two issues. You start with a relatively small pupil and you land up with a smaller pupil. Or the pupil was already small and it is not getting dilated with whatever you're doing, okay? And whatever you're comfortable with, because that 3 millimeter zone if you're getting and you're comfortable doing it there, adequate viscoelastic is important. Because once you do that, you're pushing behind, the capsule is also being pushed behind and you have enough space inside. But whenever you're pulling back the iris hook, always be careful not to take the rhexis margin also. And if you're using trypan blue, I think it will become easier for you. Since I didn't use trypan blue, I don't use it. So, I mean, it's a different scenario. But if you're using trypan blue, you can see the margins of the rhexis and that will become easier for you. Thank you.
Another important step you can do is that you inject a little bit of higher density viscoelastic helone where you are intending to put your hook. Just a little bolus, and it lifts the iris a little up, and then you can move ahead.
So we put it under the iris?
Under the iris.
Yeah.
Yeah.
You have to make space.